Thank you very much, and my thanks to the Scleroderma Foundation for inviting me. They invited me without a topic assignment, and so after several iterations, we came to this one: how are new treatments discovered? And I am not a lab researcher or basic researcher. I am mostly a clinician, but I have been dealing with issues related to scleroderma long enough, 38 years, to have seen the introduction of many treatments, some highly successful, some not. And I am acutely aware of all those issues related to scleroderma that we don't yet adequately treat. So I, like you, am very open to the ideas of what to do next to make things better. So first we have to recognize what are the needs. What are the features of scleroderma which might shorten life or diminish the quality of life? Those are both very important and very different. You could have nothing life-threatening about scleroderma, but many issues related to it that can really erode the quality of your daily existence. You can also have scleroderma as a life-threatening process. It's really, we use this one word, but there's so many different lanes of the disease, and you really have to know what lane you're in terms of, are you in that left lane of aggressive disease, or are you further over to the right with something that's a slower acting process, and it's these quality of life issues that are most important. So to know what we need to treat, first the disease itself had to be better understood, first on a clinical level, and it wasn't always understood that there were these internal manifestations. After all, the disease is named scleroderma, and systemic sclerosis as a name came later. So renal crisis as a feature of scleroderma wasn't discovered till 1952. Pulmonary fibrosis, some time around that period. Pulmonary hypertension, not until 1976. So everyone knows about them now, but 50 years ago, many of the clinical features of scleroderma, what would happen apart from skin thickening, just wasn't known. And there are other targets, of course, the skin fibrosis, the fatigue, the itching, joint pain, which was just talked about in this room, reflux, motility disturbance of any part of the GI tract, Raynaud's, digital ulcers, muscle weakness, muscle inflammation, heart inflammation, calcinosis, incontinence, erectile dysfunction. So when we talk about treatment, we have to sort out, what are we treating? Are we trying to treat the disease as a whole, or are we targeting one of those specific symptoms? And we also have to figure out, how do we assess what we're doing? What outcomes are meaningful? So certainly survival is meaningful if what we're treating is one of the life-threatening aspects of the disease, as pulmonary hypertension was, or renal crisis. But there's also symptomatic improvement. What does that mean? In terms of shortness of breath, how do we measure that? And that was talked about this morning, as far as doing six-minute walk tests or CT scans or pulmonary function tests. But we want to get people feeling better in terms of shortness of breath, what they can do, getting rid of heartburn, getting swallowing easier, diminishing their pain, diminishing Raynaud's or digital ulcers. And then we want to have some way of measuring the response other than just by asking someone, how do you feel, or how are you doing? And those are the tests that we do routinely, as far as the PFTs, echocardiogram, the right heart cath where pulmonary hypertension is concerned, the skin score that was mentioned, and on exam, what kind of joint motion there is, how many joints are tender, how many are swollen, whether the CPK or muscle enzyme is elevated, what's the kidney function, and how well controlled is blood pressure. So one way we can get answers is not feeling we're an isolated community, and recognizing that a lot of the issues that concern those with scleroderma affect a lot of other people. So esophageal reflux being maybe the most common of those that we share an interest in. And motility disturbance also is very common in people with diabetes, can have all sorts of gastrointestinal manifestations. Pulmonary hypertension doesn't exist just in the setting of scleroderma. It's one of many causes. The same thing with pulmonary fibrosis, obviously with hypertension, and also with Raynaud's phenomenon. So we have to be alert to what is being developed outside the setting of scleroderma that might be of interest to us. So sometimes we borrow solutions, and we don't need scleroderma-specific solutions for organ-specific problems. So the prime example is those agents that have been used for reflux over time. First, the H2 blockers like Zantac and Pepcid, and more recently, the era of the proton pump inhibitors such as omeprazole. Or we might discover that side effects of a drug are actually effects that for us, for individuals with scleroderma, might be beneficial. And one which I'll talk a little bit more about is the use of erythromycin for gastroparesis. And then if you have some other disease besides scleroderma, and this of course is common, that people with scleroderma may have overlap with Sjogren's syndrome or rheumatoid arthritis or lupus or some other autoimmune disease. This is the way that serendipitous discoveries are made, that a treatment that was initiated for one of these other conditions may benefit some aspect of scleroderma. And this is where your role as an observer is so important, because the physician is going to focus on the disease process for which that drug was prescribed. And you're the one who has to say, gosh, my breathing's better or my reflux is better. Otherwise, it would never come to their radar. So when we develop treatments, we also do better if we understand the disease mechanisms, and we're not just dealing with, as important as symptoms are and addressing symptoms, knowing what's the process that is producing the disease in any particular organ. And in scleroderma, it isn't one thing. We know there are different strands. There's autoimmunity, there's vascular disease, primarily small vessel disease, there's fibrosis. In certain settings, there might be infection, more often as a complication of the disease in terms of digital ulcers or someone with calcinosis. And what is or who is the at-risk population that we should treat? So we know that there are many individuals with scleroderma who will never get many of the complications of scleroderma, and we don't want to throw all these treatments at everyone. We're entering this era, 20 years into the existence of the Scleroderma Foundation, where we have hopes of knowing the molecular mechanisms. And the other issue when we try to treat something is the problem reversible? Are we just setting ourselves up for frustration trying to treat it? And our attitudes about that in terms of the conventional wisdom may change over time, that we've thought of fibrosis as a fixed problem, but we know that isn't always the case. We know that in 2/3 of individuals with scleroderma who have diffuse disease, if you follow them over time, they will get at least some degree of skin thickening even on no medication. And that's why the name was changed years ago from progressive systemic sclerosis, which didn't sound so good, to systemic sclerosis. So things that may sound irreversible may be reversible, even if we don't have the answer yet. So I want to give some case histories in brief. First about erythromycin for gastroparesis, ACE inhibitors for renal crisis, prostacyclines for pulmonary hypertension. That in the interest of time, I'm going to forego that, and also talk about one failure. And with each of these, I want to talk about the lessons that we can learn, and then move on. But I'm not going to talk about cutting-edge therapies other than how they may emerge. So research also requires funding, and this is, of course, where the Scleroderma Foundation comes in. It's also where now pharmaceutical funding comes in. But you have to know what you're asking for. So the first item I put there is awareness of need in the scleroderma community. If we're asking a question, if we're asking for funds, we have to be able to tell those we're asking what is the need, what is the most pressing need, and make some priorities. We have to be capable of advocacy, and we need allies. So in what way can research into scleroderma help others? if we can say this is something that's not just for our benefit, but is going to benefit a larger patient community, we can form a stronger force to get funding. So we need to look for what other autoimmune diseases, what other fibrotic diseases, and what other vascular diseases may benefit from advances that also help understanding of scleroderma. We need interested, motivated, and sufficiently skillful researchers, and we need communication between clinicians and basic researchers. So I don't have a lab, I don't do genomic research, but many of those who do don't know anything about the clinical needs of the scleroderma population. So it's my responsibility and that of other clinicians in the scleroderma world to make sure those needs are communicated, and we recognize who in the lab world has the skill sets or interests that can help people with scleroderma. And we have to have hypotheses that are based on well-grounded scientific evidence if we're going to make a case for funding. So we have to not chase after ideas, but build a case for why that idea makes sense. So I'm going to talk about how different drugs had very different pathways to becoming used or not used. So erythromycin is a case study of turning a side effect to good use. So it wasn't developed in a lab. It was discovered in the field, and I can't recall which organism had it, but it was discovered in 1952 to have broad antibacterial effect. And it's one of the earliest antibiotics. And early use, and lots of people went on antibiotics, as is still the case, led to the awareness of just how common GI side effects are with erythromycin. That more than 50% of individuals will get nausea, vomiting, and diarrhea. So that sounded not so good or a reason not to use the medicine, but more than 30 years after it was introduced, someone thought, it took a long time for someone actually to think, gosh, maybe there's a silver lining. Maybe we can put this to good use. And animal studies were initiated to detect the cause of the GI side effects. And they looked at rabbits and dogs who got IV erythromycin and found that it caused muscle contractures in the stomach and also further down in the GI tract. So then they looked to see why, and in humans they found that erythromycin stimulates receptors for a peptide hormone called motilin, which is normally occurring, which stimulates gastric activity. So by the late 1980s, having discovered this, erythromycin was being used for gastroparesis in diabetics. As I mentioned, diabetics have many of the same GI complications potentially as those with scleroderma, and soon thereafter in individuals with scleroderma-related gastroparesis. And the motility effect, the side effect, which we're using for gastroparesis, has nothing to do with the antibacterial effect. But this is an issue that will keep recurring, that what might work in the general population, we have to look to see if there are special issues in those with scleroderma. So first, many people with scleroderma are on medications for Raynaud's, especially calcium channel blockers, and the effect of erythromycin on gastric motility may be reduced in the setting of calcium channel blockers. Chronic use may increase the concentration of nifedipine, procardia, and cause hypotension. And there are potential cardiac side effects, prolonging the QT interval on the EKG, which could increase the risk of rhythm disturbance if you have underlying cardiac scleroderma. So there are certain settings in the scleroderma population where, although this may be a good idea, it carries more risk than in the general population. It may also increase motility elsewhere in the gut. Again, the rabbit and dog experiments showed that was the case. So that might be good. It might help you with bloating, but it might also cause problems with bowel control or diarrhea. And the effects may also diminish over time, so what works wonderfully for the first month or two of therapy may not work so well thereafter. There are other limitations of pro-motility drugs in scleroderma, not just erythromycin, but I kind of think of it like a racehorse, the difference between a racehorse and a horse that's out in the fields, that it's really difficult, even with use of a whip, to turn that horse that's used to working at a slow pace into a racehorse. And the stomach in individuals with scleroderma may not be normal and may have atrophy of the wall, loss of nerve supply, diminished blood supply, so that you give them a stimulatory drug, and not just erythromycin, but any, and that doesn't respond as briskly as you would like. So these treatments stimulate a normal stomach, but they don't fix the stomach of scleroderma. They may help with gastroparesis, but they don't make the stomach work like a normal stomach. So the story of ACE inhibitors is entirely different. Renal crisis was the most devastating complication of scleroderma, and the focus in the exhibit hall is on pulmonary hypertension and pulmonary fibrosis, because that's where the need is now, that's where the new drugs are. But renal crisis was the most devastating complication, even though it only happened to 5 to 10% of the scleroderma population, and that's still the case. Prior to the 1970s, there was no treatment, and death occurred within 1 to 3 months of onset, and there were no survivors. And that wasn't that long ago. And then in the 1970s, there was more focus on this problem, and the solutions that were first developed were rather complex, and they involved removing the kidney and putting the individual on dialysis, because if you left the kidney in, the blood pressure simply couldn't be controlled, and individuals went on to get kidney failure or strokes or heart failure. But then multiple antihypertensive drugs were developed, and they found, even before the ACE inhibitors, there were reports of success with triple drug therapy, not ACE inhibitors, using drugs in high dose in combination, you could get blood pressure control. But kidney sparing therapy was desperately needed. And in 1974, the first ACE inhibitor, captopril, was developed for the treatment of hypertension. Again, it wasn't developed specifically for the scleroderma population, but it was known to be effective when hypertension was caused by elevated levels of renin, a peptide produced in the kidney, which tightens up blood vessels. In the 1970s, it was also determined that scleroderma renal crisis was associated with high levels of renin. So people had to think about this, and we were very fortunate that Dr. Rodnan who had hypertension himself, and maybe these breakthroughs are in part related. Your antennae are out when you have the problem yourself. So that's Dr. Rodnan on the left, and Dr. Lara is on the right. And this was such a huge breakthrough in the world of hypertension, the ACE inhibitors, that Dr. Lara was on the cover of Time magazine back in the 1970s. And Dr. Rodnan, of course, was the pioneer in clinical research in scleroderma. So in 1978, captopril was first used for management of scleroderma renal crisis. So it's the 20th anniversary of the Scleroderma Foundation, but it's the 40th anniversary of use of ACE inhibitors. And there was a report of 2 patients, and I'm just going to go through the case history of one of them who was, so this is back in the day when these individual stories were so incredibly powerful. So a 25-year-old man was diagnosed with scleroderma in 1977. He had a normal blood pressure and normal kidney function. And he went on vacation with his family to Florida a year later. He developed a headache and blurred vision. He presented to an emergency room at a Florida hospital, and his blood pressure was 180 over 120. His kidney function was abnormal. His creatinine was 3, so upper limit of normal is 1.2, so it was quite elevated. And his blood pressure did not decline on conventional therapy. He was a very lucky man. He lived in Pittsburgh, and his doctor was Dr. Rodnan. And Dr. Rodnan was called because back in those days, scleroderma renal crisis was the equivalent of a general alarm fire, and any doctor dealing with it called for help from whatever quarter. But they were very lucky that this man's doctor was Dr. Rodnan. And he was aware of the work of Dr. Lara at Cornell on use of ACE inhibitors for high renin hypertension. So he arranged for the patient to be flown to New York City to receive the drug from Dr. Lara, because this was the only place to get the drug at that time. And on arrival, the patient received captopril. That was, in fact, the whole reason of his being sent to Cornell. And in 1 hour, his blood pressure fell from 170/115 to 146/96. Within a few days, it was 120/70, then 100/60. His creatinine declined, and he survived for decades thereafter. And in fact, he may still be alive. So a week earlier, a month earlier, or with a different doctor on the same day, he would have died in a month or two. So as I say, it's in this case, it was not what you know or what you don't know, but who you know. So in this case, a medication developed for a common condition, hypertension, had a mechanism of action that suggested it could be effective in scleroderma renal crisis. It was not developed specifically for scleroderma, but it immediately became the established therapy for this complication. And that happened because you couldn't, once you found a drug to be so effective, you couldn't put it through these double-blind controlled studies that were talked about, because that would be condemning those untreated to a rapid death or to having the need for their kidney removed and dialysis. So it became the therapy because Dr. Rodnan, a scleroderma specialist, knew of the most recent developments in treatment of hypertension. Now, rheumatologists often don't know that. You know, it's an entirely different field. What's being used for hypertension, it's the realm of the nephrologist or endocrinologist. But in this case, this patient lucked out because his doctor lived in a bigger realm than just rheumatology or just scleroderma. And Dr. Rodnan knew that scleroderma renal crisis was a form of what's called renovascular hypertension, and theoretically should respond to a new drug that targeted that. And he also moved emergently to get his patient treated. So in this case, the patient's fate was closely linked to his choice of doctor. But it's also a case of help delayed is help denied, that a week later, that's why he was not told to drive to New York or take a train to New York, but flown to New York, because with renal crisis, a day or two makes a huge difference. So the scleroderma community did not need to have to pay to get ACE inhibitors developed. SQUIB did this because hypertension is a very common problem, and back then there weren't very many effective treatments. So they saw the potential for a huge market and the return on their investment, and they tested 2,000 compounds trying to find one that inhibited renin and wasn't toxic before they happened upon captopril. And the mechanism of hypertension and scleroderma renal crisis needed to be clarified to know what kind of drug might help. Scleroderma specialists needed to know of the development of this drug and how to access it speedily, or there would have been no therapeutic benefit. So again, we exist in the answers for scleroderma are, maybe this will change, but they aren't going to come necessarily from clinicians or researchers specializing in scleroderma specifically. So this was the most profound advance in the treatment of scleroderma, even now. And 40 years later, it remains the standard treatment for scleroderma renal crisis. And as I mentioned, no double-blind controlled study was ever done. And we've become a little smug and self-satisfied about how much better we do, but it actually remains imperfect. That about 50% of individuals with scleroderma renal crisis, though they survive now, and we can be pretty certain if it's diagnosed quickly, they will be treated effectively, but still about 50% of individuals 40 years later still experience the need for temporary dialysis or permanent dialysis. So it was a life-saving treatment, but now 40 years later, I think there's a consensus in the research community that we need to look for ways of doing even better. We have to raise the bar. So people survive, but wouldn't it be nice if no one had to go on dialysis? So certainly it's great to know you're going to survive, but it would be even greater to know that we have a way of sparing the kidney. So this just to show just how significant this was, that the renal crisis was the cause of more than 40% of scleroderma deaths back in 1972, and now it's down maybe even lower than this in 2007, but it's less than 10%. And why is it even 10%? And that's because about 20% of the time, renal crisis is the presentation of scleroderma. Now, that's probably not really the case, but individuals will show up in the emergency room with malignant hypertension, and an astute ER doctor will notice the skin changes or get the history of Raynaud's or of reflux and think about scleroderma. But those individuals probably had those symptoms for some weeks or months before and simply didn't know what was happening to them. And so that's part of the lesson I draw from this too, that our task now is to find better medicines that will, again, raise the bar, get over that bar of just keeping everyone from the need for dialysis, but also increasing the awareness of scleroderma in the general medical community and the general community so that no one is taken unawares. So I also want to shift gears and talk about what sounded like a good idea. Dr. Merkel talked about that this morning. And now we are flooded with good ideas. And they cause a lot of optimism, and I don't want to diminish that optimism, but just that not everything pans out. So relaxin is a naturally occurring protein. It was discovered in the 1920s, and it's produced by the ovary and by the placenta in pregnancy, and it's been implicated in a number of pregnancy-related events, such as relaxation of the cervix and of the sacroiliac joint in delivery. So if relaxin did not exist, probably all pregnancies would have to culminate in a C-section. Relaxin has been around, was discovered in the 1920s, and then someone realized it had anti-fibrotic properties. It downregulates collagen production, increases collagen degradation. Sounds like just what we need, at least in the setting of diffuse scleroderma. In vitro studies, studies of cell cultures showed that relaxin acts directly on TGF-beta stimulated fibroblasts to decrease collagen secretion. So we know TGF-beta is a factor that stimulates the fibroblasts to increase production in scleroderma. So this seemed to turn it down. It reduces collagen overexpression by fibroblasts in cells isolated from patients with scleroderma. It prevents the development of bleomycin-induced pulmonary fibrosis in rats. So bleomycin-induced pulmonary fibrosis is one of the so-called animal models of scleroderma. So before you go to clinical trials, you look to see what's happening in animal models. So phase 1 and 2 studies. So phase 1 studies are safety studies, and phase 2 studies are small population studies with dose ranging. Showed recombinant human relaxin in patients with diffuse scleroderma at concentrations 60 times higher than those seen in normal pregnancy could be safely achieved with continuous subcutaneous infusion. They didn't see any toxicity from the drug. Phase 2 studies suggested that this specific dose, 25 micrograms per kilogram per day, was safe and well tolerated and appeared to be clinically effective, decreasing skin thickening and accompanying functional disability. But a phase 3 study, a larger population, not only failed to confirm benefit, but also revealed toxicity in individuals with scleroderma. So again, if you have scleroderma, a drug that may work in everyone else, that everyone with pregnancy is producing on their own with no adverse reaction, but in a population with scleroderma, you need to, safety studies really need to be done in individuals with scleroderma with any drug before a large population with scleroderma is exposed to the drug. So randomized double-blind controlled studies comparing placebo with relaxin were given to patients for 24 weeks. They looked both at men and women, and this is very important. We talked about one of the awards was to those who developed an online group for men with scleroderma. So men and women with scleroderma may have important differences. Back then, there wasn't so much appreciation of racial differences either in the severity or aggressiveness of scleroderma. But so there was no mention of that. But men and women 18 to 70 were eligible if they had systemic sclerosis with diffuse scleroderma for less than 5 years. And this was talked about also in that we want to measure treatment when the disease is still active, as opposed to someone with scleroderma for 10 or 20 years, where there's less need for any intervention. So the Rodnan skin score, which can range up to 51, that's if you have maximal tightness everywhere. You needed a skin score of 20 or 16 if there was involvement of the trunk to get into the study. Patients were excluded if they were already getting dramatically better. If their Rodnan skin score had varied by more than 5 units from screening to first treatment, and it was a multi-center study because that's the only way to get a lot of patients quickly. So patients were randomly assigned to one of the study arms, these 2 different doses of relaxin or control group, and the primary measure of efficacy was the modified Rodnan skin score. And the hypothesis was that the drug would decrease the skin score by 4 units after 24 weeks of treatment. So there were a lot of patients, mostly female, mostly Caucasian, and the mean disease duration was 2.2 years. So this was individuals with early scleroderma. And the outcome, there was a lot of excitement about the use of this drug. It sounded like a non-toxic intervention, not an immunosuppressive drug. But the Rodnan skin score was similar in all treatment groups, declining over the course of 24 weeks. So again, the natural history of scleroderma is even without treatment, the majority of individuals will have some decrease in their skin score over time, not everyone, but that's what occurred here. And other efficacy measures, looking at lung function, looking at disability index, and physician global assessment also were similar in all 3 groups. So it didn't work, but beyond that, it did some harm, that there was unanticipated toxicity. So in the study, the drug was stopped abruptly after 24 weeks. And they found that there were multiple individuals in whom the renal function declined when the drug was stopped. And in fact, in 2 patients, there was new onset renal crisis after abruptly stopping the relaxin. So no one would have anticipated this before the study was initiated. So we have to, this is why major adverse events need to be reported, and if a study is ongoing, it will influence, it may end a study or influence how it's conducted. So the protocol was changed to recommend daily blood pressure monitoring and tapering individuals off the relaxin instead of stopping it. So relaxin had no positive effects in this clinical study. So I want to move forward. So that was about 20 years ago. So what's new in 2018? And again, I'm not going to talk about specific treatments, but first, the terminology has totally changed. So what we were talking about in those previous drugs, we were talking about blood pressure measurement and skin score and measuring renin levels, and that's about as complicated as it got. But now we have all these terms that did not exist before. So proteomics is, you can look at cells in different tissues and see what is the array of proteins that are produced normally and in individuals with a disease, and looking at that over time, and looking at that in different organs in the individual with the disease. So the proteasome is the complete set of proteins expressed. Genomics is the study of the full genetic array of an organism and how people with a disease differ from normal controls. And this GWAS studies, a genome-wide association study, is to look at the what genetic variants you can pick up when you look at the whole genome in individuals with a disease. And you'll read about cytokines and chemokines. So cytokines are signaling molecules that are secreted by certain cells of the immune system to act on another cell. So they are sort of hormones writ small. So we're talking about the cellular level. And then chemokines are a special kind of cytokine that make cells move, that draw them to a site of inflammation. So the terms in 2018 have changed entirely. Those words didn't appear 10 years ago, certainly not 20 years ago. And what is this going to do? Well, it's going to make for more individualized treatment, even if individuals appear to have the same disease. You know they have diffuse disease, and you know they have rapidly progressive diffuse disease. In the past, we might have treated them all the same. So I'm not going to try to understand or even interpret this sentence, but other than to tell you that when individuals differ in their response, we're getting close to understanding why. And as in rheumatoid arthritis, once we have an array of drugs, our job is going to be, instead of trying one after another, and or you go to the shoe store and they bring you 6 pairs of shoes and you try them on and see which one fits, it takes some time to do that. And if you know your shoe size and if you know what you want, you can be in and out of the store a lot more quickly. And you also have to know that that shoe store stocks what you want. So I'm just going to, I have difficulty with these long sentences and long words and just kind of read through it with you. But so imatinib, which was studied at the Hospital for Special Surgery in scleroderma, has been investigated in multiple trials with highly variable results. Investigators attempted to determine whether baseline measurement of cytokines, chemokines, growth factors, or autoantibodies were predictive of clinical improvement with the drug. And they identified a multi-analytic signature based on baseline levels of CD40L, CXCL4, and this antibody PMSCL100 that was predictive and accurate. Well, this would still be Greek to most clinicians, but it tells us that if we know enough, not about pulmonary function tests and the CT scan, but about what are the cytokines, what are the antibodies that you individually have, we may be able to select a perfect match for you from what may be a big array of anti-fibrotic drugs in the future. So basic research has led to identification of a large number of cellular and molecular key players in the pathogenesis of fibrosis. So many, and they each have advocates, and this isn't the world's most common disease, so now there's difficulty selecting among drug options, difficulty filling drug trials. How can we select the best candidate drugs among an increasing number of options? So in the past, and still for some problems like calcinosis, as you heard, we don't have a drug for calcinosis. There are some single center studies. So in vitro models, animal models, pilot studies in a small number of patients may all carry false promise. So what works in the lab in a cell culture, what works in a rat or a mouse or a rabbit, and even what works in a pilot study of half a dozen patients may not work when it's tried in a much larger group. So how do we make more progress? And again, that's the title really is, how do we discover new drugs? So first, this is well in progress, is the development of a scleroderma research community. So every 2 years, there's something called the International Workshop on Scleroderma Research, which is held either in Cambridge, England, or in Boston or Pittsburgh. And it's a meeting of scleroderma researchers, clinicians, and those who are more laboratory-oriented. But it isn't just that. It's also the people who organize this meeting try to identify basic researchers in other fields who may know nothing about scleroderma, but who have ideas that may be relevant to the treatment of scleroderma, and to bring them into talk, and to talk with two purposes: to educate us about what's going on in other fields, but also to get them aware that there's a clinical need that their work may really impact. And this has worked on many, many occasions to get researchers who were not involved in scleroderma at all excited about scleroderma, aware of scleroderma, recognizing that they might contribute to advances. And the other was in Europe with USTAR to meet with representatives of industry, of pharmaceutical industry, and the same thing, trying to get pharmaceutical companies aware of the needs of the scleroderma population, and especially those needs that might lead to advances in other realms as well. And a lot of these things did not exist 20 years ago when the Scleroderma Foundation started. There was no USTAR. There was the beginnings of this workshop. That already existed. But this journal is new. It started in the last 5 or 6 years, this Journal of Scleroderma and Related Disorders. there's a big enough community now interested in reading about scleroderma research to support this journal. And there's the Scleroderma Clinical Trials Consortium, which was mentioned again, which is now maybe up to 100 centers worldwide, that if someone has an idea or a pharmaceutical company is trying to find sites to do studies of drugs, there is now this worldwide network of scleroderma centers to approach. So what are the challenges in drug discovery and drug trials? So again, funds are needed to do any of these studies, and we have to generate industry interest in scleroderma or NIH interest in scleroderma. We have to work really hard on patient recruitment, and that's because, again, scleroderma is relatively rare, and the natural history of the disease is such that we have to find the right sort of individual at the right moment in time. So individuals who've had scleroderma for 10 years have a set of problems that are largely different from those with early disease, 1 or 2 or 3 years into the disease, where there may be lots of fibrosis, worsening of skin, lots of itching, problems that may have resolved 10 years later. And so those individuals with disease of a decade duration aren't suitable candidates for studies of drugs for fibrosis. We're now in a realm, as I mentioned, where there are lots of drugs, there may be competing trials, and with limited knowledge, how do we know we're directing an individual to the right trial? And we do know that patient subgroups may respond differently, as I mentioned, male versus female, Caucasian versus Black or Asian or Hispanic, older versus younger, that there are generally greater toxicities the older the population. And we have to, in anyone with scleroderma, again, we're not dealing with one entity. Different organs may be involved, and that may impact issues of drug safety and what their health risks are over the ensuing years. And with drug safety, the population with scleroderma, again, has to be looked at on its own terms, that a drug that's been tested in healthy 18 to 20-year-old volunteers, that may not tell us very much about the safety in individuals with scleroderma. So I mentioned we're a relatively small community, and so we have to look for allies. And there are many potential allies. Some are involved, some are not. So the PHA is the Pulmonary Hypertension Association, which is a very active group. And if one of their meetings would probably have many of the same exhibitors that are present here. But there's certainly a shared interest in treatment of pulmonary hypertension. The American Heart Association has an interest in pulmonary hypertension and in renal crisis and the management of hypertension. The American Diabetes Association may not know how much they have in common with scleroderma in terms of they may not know, someone there, about scleroderma or that gastroparesis is a problem of scleroderma, but we want to make sure they do know. So when treatments come up for scleroderma, for diabetic GI disease, that they work with us. There's a vasculitis foundation. Vasculitis is not usually very prominent in scleroderma, but this is a group interested in how to manage small blood vessel disease. And HHT stands for hereditary hemorrhagic telangiectasia. This is a very rare disease, but they get blood vessel changes that are identical to the telangiectasia that occur in individuals with scleroderma. And I just wrote the director of this group yesterday just to see if they had any connections with the scleroderma world, with the Scleroderma Foundation or Scleroderma Research Foundation, and they don't. But these individuals can get GI bleeding, they can get pulmonary hypertension, they can get nosebleeds, and they might be misdiagnosed as having scleroderma, or someone with scleroderma might be misdiagnosed as having hereditary hemorrhagic telangiectasia. Well, it turns out they're focused very much on purely vascular small vessel disease issues, not fibrosis, because fibrosis doesn't occur in HHT. And they have studies in their population that may be very helpful in scleroderma in terms of controlling bleeding from vascular malformations in the GI tract. So I think I put them in bigger size because there's actually, along with the Pulmonary Hypertension Association, there's great potential for working together. There are also allies in the world of fibrosis. I left out one, but there is a Pulmonary Fibrosis Foundation. So pulmonary fibrosis, although it's a problem in scleroderma, isn't a problem exclusive to scleroderma. And there's the American Liver Foundation because cirrhosis is a fibrotic disease as well. And it turns out there's a lot of interest in cardiac fibrosis. And in the last week, I got a text from a friend who'd gone to a talk. He's a rheumatologist, but not in the scleroderma world, on cardiac fibrosis and the role of something called interleukin-11. And interleukin-11 may be the mediator of the effects of TGF-beta. That is, interleukin-11 may even more directly stimulate, play more of a role in directly stimulating the fibroblasts to make collagen. And so it's been studied, not in the realm of scleroderma. There is no paper on scleroderma and IL-11, but in the world of cardiac fibrosis. And so he's the sort of speaker, the cardiologist working on cardiac fibrosis and interleukin-11, that we seek out and try to invite to this scleroderma workshop and see if his work is relevant to scleroderma. And then we certainly, of course, know scleroderma is an autoimmune disease, and it can overlap with rheumatoid arthritis, with lupus, with Sjogren's, with polymyositis or dermatomyositis. And so there's this bigger world of autoimmunity out there, and there certainly is crosstalk with all these organizations and scleroderma. But the answers for scleroderma may come from the realm of one of these other diseases, or the answers for these other diseases may come now that research is being done on scleroderma specifically. What we do may help individuals with these disorders. And many of these individuals, as I mentioned, many people with scleroderma may have one of these diseases already in overlap. So how can you help? So the first thing is to be a careful observer of your health status. New symptoms may or may not be related to scleroderma or to drug therapy, but should be reported so that we can help you with the interpretive process. Or if it's a study where there are 50 centers, an individual report may not mean much. It might be coincidence, but if it turns out that from 20 of those centers, individuals are reporting the same problem, this is a really important story. So I mentioned with relaxin, if there had just been one individual who had kidney problems, maybe it wouldn't have caught so much attention, but it was multiple individuals. Be an educator of others, especially health professionals in other fields who report little familiarity with the disease. So there are still certainly parts of your own body that if affected by the disease, you're treated primarily by a rheumatologist. We have little expertise when it comes to issues of incontinence, infertility, or many neurologic symptoms. We have a lot to learn about the more obscure corners of scleroderma and whether there is involvement in organs that we don't even appreciate are involved by the disease. Maybe they're not, maybe it's just unrecognized. Consider seeking care at a center affiliated with Scleroderma Clinical Trials Consortium, especially if you have early diffuse disease, so that you can have access to clinical trials. You may not want to, but that option doesn't exist at some place that is not a participating center. And also be alert to health and science stories that may be relevant to scleroderma. So when I walk into a room with a patient, I used to think that I would be confronted with a lot of questions. But my mindset has changed. And when I walk into the room now, I think I may be walking into the room that will give me the answer. And I have a couple illustrative stories, but one was an individual who had calcinosis as well as pulmonary hypertension. And she went on therapy with treprostinil, Remodulin, sub-Q Remodulin. And I didn't prescribe it, the cardiologist did, but it helped her. But she came in 3 or 6 months later, and she said, my calcium deposits have virtually gone away. And we still don't know whether that's meaningful or not, but because there was no treatment for calcinosis, my ears perked up. I took x-rays of her forearm where the calcium had been, and it was indeed almost gone. Now, that's what's called testimonial medicine. So an N of 1 is not really helpful, but actually it led to consideration of why it might work and whether calcinosis was really a manifestation in a different form of the same kind of vascular damage, vascular obliteration that causes pulmonary hypertension. That is, does calcinosis result from persistent tissue hypoxia at the fingers? So with the help of a pharmacy student who is here, we tried to come up with an explanation, a mechanistic explanation that might make this story make sense. And it turns out there is something called hypoxia-inducible factor, which we all have in all of our tissues. It's our oxygen sensor, just like a sensor for the fire alarms. But it is deactivated in the setting of normal oxygen. And most of the body has a normal oxygen level. But it accumulates where there is persistent tissue hypoxia. So in the fingertips, if you're one of those people walking around with digital ulcers or shortened fingers or calcium deposits at your fingertips, we can be pretty certain that you have high level of hypoxia-inducible factor. And this hypoxia-inducible factor, I had not heard of a couple of years ago, because the person who discovered it actually has never written about scleroderma. And no one who's written about scleroderma has really looked at hypoxia-inducible factor. But in the fingertips, hypoxia-inducible factor causes breakdown of bone. And if the circulation is very poor and you lose some of the bone at the finger, it may not travel very far. And we know that you can get big calcium deposits right next to areas that you've lost a bunch of bone. So treprostinil is one of the drugs being studied now for calcinosis. And this might be the mechanism that it somehow increases perfusion of the fingers, but it's certainly too early to say. So we're trying to turn the observation of one patient about one calcium deposit into something that we can explain at a molecular level and see in a larger group of individuals whether it makes a difference. And the other time this happened, which was also where I have treated several individuals with a very rare disease called Dago's disease, which up to about 10 years ago, if you looked at the literature, there were 200 reports that all ended with death. And it's very similar to scleroderma in terms of what it does to blood vessels, that it causes obliteration of small blood vessels. And what they die of are strokes or bowel infarcts, not problems that happen to people with scleroderma. But there was no treatment. And very occasionally, very, very occasionally, it can overlap in individuals with scleroderma. And this woman came in and had pulmonary hypertension. She had scleroderma. She had skin lesions that were Dago's. This is rare, but not unique in the setting of scleroderma. And she said on this treprostinil, my breathing is much better, but my skin lesions have also gotten better. Now, if she hadn't told me that, I wouldn't have been looking, but this suggested this drug might make sense for this Dago's disease. And so we put it to work for someone who was deathly ill, and because there was no treatment, and it actually did work. And so again, problem N of 1. We've tested it in several other individuals, and we're trying to figure out, same thing, if we can explain why it worked. But I want to express these stories to tell you that your observations can be incredibly powerful and often maybe not meaningful, but sometimes they are, and they're certainly worth expressing. So the other way you can help is that we need antennae. We need to be like centipedes rather than six-legged insects. So I received a text from a patient a few weeks ago as I was preparing the slide set, and she had a family member at the University of Pennsylvania, and so here we are in Philadelphia. So she said, although the researchers at UPenn Dental School are investigating this for reasons unrelated to scleroderma, I thought it might interest you. Turns out in the dental world, they're very interested in angiogenesis in blood vessels as well. If you have poor flow, you're going to get gum recession, you're going to get more dental decay. So she sent me this link, and it was about this peptide that was felt to be a key to angiogenesis. So it wasn't in the scleroderma literature, and I don't read the bulletin of the UPenn Dental School, but thankfully one of my patients does. So I told her, I thanked her. I said, this is great. I'm not sure how far I will be able to carry it, but I will at least look it up. So she wrote me again, and she said it's, I should say she was a triathlete, and from her scleroderma, she's pretty much housebound, and a very, very bright woman. And so she has lots of skill sets, some of which she's lost or can't exercise, some of which she can. So she wrote, it's fun and rewarding for me to stumble up and share these articles with you, especially if they might one day prove to contain an ingredient of the special sauce that might help others like me. And so to me, that was, it made her days purposeful to do that task, even though she cannot be a triathlete or a health professional, which she is also. So I just want to talk about my own credo, which is three things, which I think in terms of coming up with the answers and finding others who will help us find the answers are important. So the first one is manifesting, and that is walking around purposefully in terms of knowing what your goal is. And so again, it's just like coming into this building and knowing what room you're going to. And you might ask directions to get to that room, but you know where you want to go. Now, of course, there are 7 lectures going on simultaneously, and it can be, for those of us who have difficulty making choices, you know, if you're not really directed, what can happen, of course, is you wander around, you miss half the lecture because you haven't made up your mind. But so manifesting really means you are directing yourself, you have a target, and you will do whatever you need to do to get there. So the second is being open to serendipity. So this is really important. Serendipity is not blind luck, or it's not like a blind date, or however it is knowing, you know, on that blind date or whatever, that you already know who you're looking for, and you happen to have found that person. That you know, that stranger circumstances you meet, and this person or this idea answers exactly what you're looking for. Now, it is related to manifesting, because again, if you are walking around and you have no idea of the sort of person you want to meet or the sort of idea you need, you're not going to meet that person and you're not going to come up with that idea. So serendipity means when something crosses your path, if you know what you're looking for, you will recognize the importance of it. And it happens all the time. But again, it happens, as they say, to the prepared mind, that you have to know what your need is, and then the most chance encounter may be incredibly significant. And those 2 stories from my patients about the calcinosis and about the Dego's disease, they certainly were serendipity, and they could have walked out of the office and told me nothing. And the third part of my credo, which is the one I learned most recently, is exercising the power of entrainment. Now, I didn't really know this word, and I'm a little embarrassed to say I learned it on Shark Tank. But, because someone had this, developed this float device or a pool that you could blow up. You didn't even have to put your lips right on the seal. And it turns out that when you kind of blow, that there are all these little particles floating around with no direction. But if you give them direction, they will follow you. You know, so you can get all these air particles to expand this flotation device. And so if there's 600 people milling around here who want to do something for scleroderma, but really have no idea what to do, if at that luncheon you announce you have a plan and you can convince them that it really is a compelling plan and a great idea, and say, we're going to march to City Hall, instead of you're marching there by yourself, assuming that had some purpose and a reasonable outcome, you don't have to walk out of here by yourself, but you can walk out of here and see that you have 600 people following you who they had the energy, they had the willingness, they just needed the direction. And so that's what entrainment is, that you form an idea that is powerful enough that it can motivate others. And so what you can't accomplish by yourself, you can, and you don't generally encounter much resistance when you do that. It's you know, it's the difference between thrashing around in water because you don't know how to swim and getting from one end of the lake to the other because you do know how to swim. And it's both people are in the water and one is having a terrible time and the other is accomplishing a lot. So I want to thank my mentors. I happened to arrive in Pittsburgh at the time, was I think the golden era, and that Dr. Rodden, Dr. Metzger, and Dr. Steen were all there. And like many other individuals, I encountered scleroderma knowing nothing about scleroderma, and it's, again, an instance of serendipity, looking for purpose for myself and finding these very purposeful people who could inspire me. And I want to thank my colleagues at the Stephan Scleroderma Center in Albany and Saratoga, Jessica Farrell, who will be speaking, Vivek Mehta, who was a fellow working with me, Mitchell Miller, pharmacy student, now pharmacist, who's here, and my research coordinator, Roberta. And I want to thank my patients, because again, they ask a lot of questions, but they give a lot of answers. The Scleroderma Foundation, especially, I wish you a happy anniversary, 20 years. And to the Ann Stephan Scleroderma Research Foundation, which exists up in Albany. And Ann Stephens died about 35 years ago of pulmonary hypertension. We had no treatments then. And I know she would be alive now had this problem occurred 25 or 30 years later. So the world changes. In the realm of scleroderma, I'm quite sure it's going to change for the better, and I'm quite sure that with your help we can speed it up. So thank you very much.